I want to get started. Dr. Alyssa Stephenson-Famy, who has presented before, comes from the Department of Obstetrics Gynecology, has been a fantastic content expert, has contributed not only to our previous programs, but has led, and we were just chatting, thank you very much, a major contributing role to the new Washington State Agency Medical Directors Group, or AMDG, guidelines on opiate prescribing with a new section on opioid use in pregnancy. So this, she tells me, is going to be tightly linked, so that I'm sure we'll be able to give you the reference to that content as well. So without further ado, we do have two cases after, but that should give us enough time for a non-out-of-breath presentation. Yeah. That's my usual style, but Dr. Stephenson-Famy will be speaking on pain in pregnancy and a general disclosure. This is part of our opiate REMS, risk evaluation mitigation strategy component of our program, UWTelePain. It's intended to be compliant with the early opiate REMS activity, and participants who complete the full sequence and complete the examination questions at the back end will be called a REMS completer, and we're hoping to accomplish not just activity participation here, but the completion of the examination at the end. So more on that later, if necessary, and we'll just move forward. Thank you, Alyssa, for coming today.
No problem. Well, I'm always happy to talk, and because I am kind of aligning the talk today with the new Washington State guidelines, I will focus mostly on opioids. Our guidelines don't really talk about alternative treatments to pain in pregnancy, although that is a whole distinct and important topic. So I will spend most of the time talking about opioids, and then perhaps when I come back next, I'll talk about a little bit more about alternatives to opioids in pregnancy. It's always nice to be the content expert of a field for which there is almost no data, because then it makes my job a lot easier. So hopefully I will give you as much data as there is. I have no financial disclosures or conflicts. And so the theme of this talk is how to basically avoid opioids. And primarily what we talked about in the Washington State guidelines that will be coming out soon is really emphasizing the risks of opioids in pregnancy, as we know that there are not many benefits to using opioids in pregnancy. And then we'll discuss a little bit the role of taper and detoxification, which is quite controversial and a little bit more challenging, but I'll give you the general principles. So pain in pregnancy is ubiquitous. I will just say that every woman has some pain complaint. 2/3 of women will have low back pain, and up to 1/5 of women will complain of pelvic pain. These are probably the two endogenous types of obstetrical-related pain that we hear about, and this is due to many physiologic changes in pregnancy. There also can be acute exacerbations, and then when everyone has a chronic musculoskeletal injury, and then pregnancy is superimposed, that just makes everything worse. And so it is a very frequent issue for people to complain of pain in pregnancy. At every prenatal visit, I will hear of some pain complaint. And usually we can address them primarily with reassurance. That's my primary strategy. Just reassure them that it's normal and that it will get better postpartum. There are a number of non-pharmacologic therapies, and this is, although I'm not going to emphasize this is a recent Cochrane review that looked at a number of different non-pharmacologic modalities, including acupuncture, physiotherapy, different types of exercise, osteopathic manipulation, and even simple interventions like a support belt. And basically what they demonstrate is that there is low to moderate quality evidence. Remember, all of these studies are small, they're usually underpowered, underfunded. When put together in a Cochrane review, it looks like there is some reasonable quality of evidence to suggest that a lot of these treatment modalities may be successful for the treatment of lumbar, lumbopelvic, and pelvic pain. And so before we even talk to our patients about opioids, long before that, we should be mentioning that there may be some data for use of these alternative strategies. I also think that I cannot emphasize enough how much I think the psychosocial contributors to pain make people less able to tolerate the pain of pregnancy. And this may be due to psychiatric conditions, social stressors, and oftentimes I worry a lot about patients who complain of different types of pain symptoms about intimate partner violence. So these are things that you definitely want to screen for when patients are repetitively either asking for pain medications or are complaining of pain symptoms in pregnancy, make sure that they're actually able to cope appropriately with the pain they have. And if you can at all hook them up with counseling, social work, or other sorts of resources, I think this can be tremendously beneficial. So when we think about non-opioid pharmacotherapy, we have very few options, unfortunately. Non-steroidal anti-inflammatory medications, which are the kind of treatment of choice in the non-obstetric population for many types of pain, are essentially considered either Category C or Category D, depending on the trimester. First trimester use is not strongly associated with fetal anomalies. However, in the second and third trimester, it's associated with two major things. One is oligohydramnios, or low amniotic fluid, and that's with chronic use. And then premature closure of the fetal ductus arteriosus actually is an irreversible phenomenon, primarily with chronic NSAID use over 30 weeks. So I always tell patients that a very short course of NSAIDs, we use it for tocolysis, when people have preterm labor, for surgical or acute musculoskeletal pain may be reasonable. But anything longer than a 48-hour course of NSAIDs is usually inappropriate in pregnancy, unfortunately. Now, Tylenol is considered a Category B medication. B is relatively good. All these pregnancy categories are actually going away per the FDA as early as this summer. But so far we have reasonable safety data for Tylenol. Unfortunately, it's not terribly effective for many of the types of pain that patients complain of. I always worry a little bit about the toxicity of overdose, so we have to be aware that that could affect both mom and the fetus. And then there are a lot of studies looking at contributors to autism that look at every exposure you could possibly have in pregnancy. And one of the recent studies is actually on Tylenol. I don't think the data is particularly strong, but it may be something that our patients bring up when you try to give them Tylenol for some pain symptom. So then we're left with opioids. And I would say in general, there has been just an incredible increase over the last kind of 10 to 20 years of rates of opioid prescriptions amongst both reproductive age women, so women kind of aged 15 to 44, and then also in women during pregnancy. And there's a few pretty notable recent publications in 2014, 2015 that highlight these rates, which are much higher in Medicaid populations than in women with private insurance. But that may range up to 39% of just the general women who have Medicaid, and 21% of pregnant women who have Medicaid actually filled an opioid prescription during their pregnancy. So that clearly illustrates a tremendous problem that we have. And then another publication documented a 4-fold increase in the rate of opioid prescriptions to pregnant women over the last 10 to 15 years. And I think this just speaks to some sort of kind of either pervasiveness with which patients are asking for it, or that physicians are just prescribing them, physicians and other providers are prescribing them more liberally. And I think we have to be very cautious with this. In general, pregnancy is a different physiologic state than being not pregnant. And there are many reasons why pregnant women actually metabolize opioids and other medications differently, and that may include things like the high volume of distribution, change in protein binding, the increased rate of hepatic metabolism, and significant increase in your glomerular filtration rate and renal clearance. And so therefore, women who come into pregnancy who are already on chronic opioids may actually require an increase in their dose or an increased frequency of their dose to prevent withdrawal symptoms. So that is actually not an uncommon complaint of women. And then another hugely important principle is that when women then are pregnant on opioids and then go in to deliver, they have a lot of additional pain symptoms with labor or with surgery, and that may make their anesthesia much more complicated. So the teratogenicity data for opioids is actually a little bit controversial. The data is not strong, and so the American College of Obstetrics and Gynecology has basically come out with a statement that basically says there's no clear pattern of teratogenicity of opioid use during the first trimester, but there are some recent epidemiologic studies that demonstrate an increase in several different types of fetal anomalies, such as neural tube defects, abdominal wall, and cardiac defects. The problem with kind of proving causality is that there's a baseline risk of congenital anomalies in the general population of about 2 to 3%. So showing that there's a really significant increase of specific types of anomalies with opioid use exclusively has been really challenging. But I think that there is some reason to be concerned. Also in recent publications, there are some associations with opioid use in pregnancy and multiple different types of adverse pregnancy outcomes, including preterm delivery, poor fetal growth, and stillbirth. Women who use opioids in pregnancy may have higher rates of depression, anxiety, and other medical conditions. And this results in potentially an increase in healthcare costs. Now, this data is not very strong in the sense that it is highly complicated. The patient who is on opioids during pregnancy and the patient who is not are usually very different from each other, and there may be a lot of comorbid medical complications, obesity, differences in socioeconomic status, nutritional status, and then use of other drugs and alcohol that make this data very difficult to interpret. So although I think this is in general true, opioids are kind of either a marker for pregnancies that may not go well or may actually contribute to pregnancies not going well. I think that this is another site of caution for use later in pregnancy. Now, we know that opioids have a very direct effect on fetal neurobehavior, and so after dosing, say, of long-acting opioids like methadone, the fetus actually will have decrease in the heart rate, decrease in the variability of the heart rate, less motor activity and breathing, and that will result in some non-reactive, non-stress tests if you're doing fetal testing right after medication dosing. And what this may look like is that long-term, after the baby's born, that there may be feeding difficulty in opioid-exposed infants because there may be some actual alteration of sucking patterns due to effects on the brainstem, respiratory, and swallow centers. So we know that this is obvious. Clearly, opioids cross through the placenta and affect the fetus in many of the same ways that it affects the adult who's taking it. But it's something that our patients need to be aware of, that when the baby is delivered, may have altered kind of feeding issues. Now, the true crux of this problem is that we've talked about all these kind of epidemiologic studies that look at teratogenicity and look at some of the adverse pregnancy outcomes, but neonatal abstinence syndrome is real. And unfortunately, it's on the rise. There's a recent publication that cites that there's an increase actually in NICU admissions. It's a recent New England Journal article nationwide for NAS. So this is something that our patients absolutely need to be aware of, and is actually a tremendous deterrent to either seeking opioids or taking them during pregnancy. So of infants exposed, the rates are anywhere from about 30 to 90% of babies will require treatment for neonatal abstinence syndrome. And these symptoms are wide-ranging, but include in general irritability, tremulousness, sweating, nasal stuffiness, poor suckling, diarrhea, vomiting, and even seizures. The postnatal Finnegan score is used for pediatric inpatients to score the grades and degree of the psychomotor irritability and some of the vasomotor and GI disturbances, and may be indicators that babies need additional treatment. Now, just in the state of Washington, our rates of neonatal abstinence syndrome have increased dramatically. Now, I think in part of this is better recording. So this exact finding has been reported in various different states nationally, and I think that the recording and coding of NAS as a specific diagnosis has probably improved tremendously. But this type of data actually makes me highly concerned that there is a more permissive use and seeking and prescription of opioids during pregnancy that is resulting in significant pediatric outcomes. So in general, the timing of NAS is important because most babies will develop symptoms within the first 72 hours, but they can occur anywhere from the first 24 hours to day 14 of life. And unfortunately for women who've had a baby in the hospital, many will go home on day 1 after delivery, and so if you have a C-section, maybe day 2 or day 3. So there is a possibility that we're discharging these babies from the hospital even before they develop the signs and symptoms of neonatal abstinence syndrome. For women who we know are on methadone or are on chronic, especially long-acting opioids, we will watch these babies more closely. But I'm actually a little concerned that some of our patients aren't telling us that they're using them, aren't telling us that they have the prescriptions at home, that they got out of pregnancy or from someone else, and that these are babies that we may miss. Interestingly, the maternal dose does not correlate directly with rates or severity of neonatal abstinence syndrome. So they've done some studies actually in methadone, which is probably the best studied population. At very high doses of methadone, the vast majority of babies will develop NAS. But the dose does not exactly correlate, unfortunately. And for women who are on opioid replacement, buprenorphine is actually associated with a lower incidence and a shorter duration of NAS. So maybe an alternative for women who are on opioids, not for pain, but for opioid replacement. Opioids and lactation are an important topic because, again, as I'm talking to women about the counseling, about the decisions of what to do to treat their pain during pregnancy, I always want to address the safety concerns of, are they able to take these medications after they deliver while they're lactating? And essentially, the American Academy of Pediatrics basically says that women who are on opioids, it's not a contraindication to breastfeeding, even though babies do receive a small percentage of the weight-adjusted maternal dose via breast milk. So for women on, say, chronic methadone therapy versus women who just get short-acting opioids at the time of C-section, essentially that's permitted and the babies have fairly minimal effects. Interestingly, women who breastfeed who are taking kind of long-acting opioids or methadone, and then what we've seen is that the babies actually have a little bit less NAS, probably because they are getting some opioid replacement through the breast milk. So we support breastfeeding because it has many neonatal and maternal benefits, and certainly this context is not an exception to that. So if opioids are bad, the first rule of thumb is do not start them. Do not start them before a woman gets pregnant. It's probably the single most important thing you can do, because then once you have a woman who gets pregnant and they are on opioids, you have a big problem on your hand, because then you have to figure out what to do with that. The next thing you should remember is if someone is actually pregnant, do not start them. So try to figure out some other way to get them through the pregnancy using alternative therapies, mechanical therapies, non-opioid therapies, because starting them creates a situation in which you have the potential for NAS. So if you have a woman who comes into pregnancy on them, you're in a little bit of a bind, because although we would very much like to minimize the maternal-fetal opioid exposure, we would love it if there was no overdose or diversion in our pregnant patients. We are slightly worried that if women go into opioid withdrawal in pregnancy, that actually leads to other pregnancy complications like preterm delivery and fetal distress, and even old reports of miscarriage or stillbirth. So in general, we support this idea of people taking the minimal amount of opioids, but how to get them there is actually a little bit tricky. So this is what I was just mentioning in terms of the old associations, and these are very old literature, like 50s, 60s, 70s, looking at the risks associated with opioid withdrawal during pregnancy. Now, the problem is, if someone's on opioid replacement therapy because of a history of illegal drug use, and then you take them off of what they were using to replace that, there's a risk that they will turn around and use illegal medications again. And that sets them up for infectious kind of exposures, losing their children to CPS, getting imprisoned at some point. So that is clearly a bad idea. But what to do with women who are taking it for pain is actually a different issue. So there has been some publications, 3 in the last 10 to 15 years, looking at inpatient opioid detoxifications. And it looks like it may be a little bit successful if success is no increase in complications and no recurrence of use. But there has been no reported adverse outcomes in these 3 series of looking at things like pregnancy loss or preterm delivery. And that's when they were tapering at less than 20% of the stable daily dose every 3 days as inpatients. So clearly this is not a model that we can really promote in many of our patients who are taking much lower doses and are not clearly candidates for inpatient therapy. Now, the decision to proceed with opioid detoxification, if you want to do that, is complex. And again, the safety for it is debatable for women who are clearly on small doses and who don't really need it. It seems ideal to take them off of it. But what I don't want to see is I don't want to see women who get pregnant on chronic opioid therapy, then their providers are all of a sudden uncomfortable with the fact that they are now pregnant on the chronic opioid therapy they have been on for a long time, and now they find themselves without an obstetrician that's comfortable and without a pain medicine provider that's comfortable. And I've seen that play out, and it is not good for patient care. It's not good, particularly good for the mom or the fetus. And I think having a plan on the charts to say, this person is a reproductive age woman and could become pregnant at any time. What are we going to do about her opioids if she does become pregnant? So avoid use preconception. It's a major pearl. Avoid use during pregnancy or initiation if you possibly can. If you do need to initiate it, it requires counseling and documentation that you've talked about the risks of NAS. Consider an anesthesia consult and perhaps an inpatient pediatric consult at the hospital that the patient will be delivering to make sure that that hospital is comfortable caring for a baby that could develop NAS. And then consider getting additional consultations if you're thinking about transitioning someone off their opioids, especially if it's a formal detox process. If it's just tapering down because they're on small doses of short-acting opioids, I think that is much less controversial. You can probably just do that kind of very quietly. But if they're on hefty doses or say somebody wants to come off a high dose of methadone, it may not be realistic, or they may need to go into an inpatient treatment program. This is just a quick plug for this program that sponsored a Twitter campaign to highlight this particular telepain lecture. And I'm happy to take any questions with our remaining 4.5 minutes.
Okay.